Okay, so good afternoon, everybody. Thank you for joining us for our talk on We Don't Talk About Failure. I am Dr. Tamara Goldberg. I am joined today by three colleagues, Dr. Devorah Edelman, Dr. Andrew Young, and Dr. Eric Udelovich. And we would like to start by thanking the Alliance for Academic Internal Medicine for inviting us to speak on this important topic of really shame in medicine. So before we begin, we want to hear from you, and you can use the chat function to do this. What are some words that come to mind when you think about a professional failure? Just first words that come to mind. And you can enter them into the chat. Okay, great. I see stress, very common reaction to failure. Other thoughts? Growth opportunity. I love that. Disappointment, guilt. Yes. So this is when you read the literature on failure in medicine, these words come up a lot. New roles, imposter syndrome. Excellent. So when we think about failure in medicine, let's start by talking about success. We do a great job of highlighting successes in medicine, and yet we tend to suppress talking about failure. And what that does is creates this illusion that somehow career trajectories are these linear paths of successes, when for most of us on this call, we know it's those moments of failure where we had to pivot, and ultimately were incredibly impactful in shaping who we are professionally today. So our objectives today are to first to identify the benefits of normalizing failure in medicine as it relates to medical education, and to develop the skilled approach toward analyzing our own professional failures. And I very intentionally put failures in quotation marks, because I think this is an opportunity to reframe how we think of failure and what we consider failure in medicine. Oops, sorry. Let's take a moment of self-reflection. So for those of you listening in, think of a time when you failed in medicine, and keep this in the back of your head, write it down. It may be you failed an exam, you failed a course, you didn't get a position that you applied for, your paper got rejected. Keep one example in the back of your head as we go through this presentation. Now, chances are the road ahead seemed blurry after you experienced this failure. Perhaps you didn't know where to go next, or perhaps even who you should talk to about the failure. And that's one of the reasons we're here today, is we need the skill set to not only approach failure in ourselves, but in our trainees as well. And it's important to understand those emotions that you all mentioned earlier about failure. I love this quote because I think it resonates with many of us. The most important thing I've learned is that I couldn't address my failure alone. Concealed failure welcomes shame and hopelessness. Failure can be a dark and self-deprecating place when handling it alone. And we know that there's a healthy amount of stress, frustration, guilt, someone mentioned earlier, that can actually push us forward. But so often in medicine, it's shame, and shame can be destructive towards moving forward from that failure. And so we've sort of been primed in medicine to have a poor response to failure. This is a result of both individual factors, right? And I'm sure you can add to this list. We tend to be competitive with ourselves, with our peers. We have perfectionist tendencies. For many in medicine, success is the norm. I remember a resident in clinic recently told me, Dr. Goldberg, failure means that you weren't perfect. Failure means that you weren't perfect. That's a huge burden to carry. Perhaps we have inadequate skill sets to know how to manage failure. And some of us are harboring this burden of expectations from others to succeed. And then there are structural factors. We operate in a system with constant ranking and assessment. There's a focus on performance and evaluation, right? Rather than being vulnerable, encouraging vulnerability, focusing on growth. Stakes are high. There's a demand to be resilient, have a thick skin. And for many, there are few, if any, spaces to reflect on failure and to have dialogue about failure. And there's a lack of psychological safety. This is particularly prominent in the literature on underrepresented colleagues and peers in medicine, that there's a lack of psychological safety embedded within our training environments. And so all of this leads to these feelings of shame, isolation, unworthiness, and often this sense of a globally flawed self. And for medical students, for residents who, their day in and day out is medicine, their personal identity often combines with that professional identity. And so a professional failure feels like a personal failure. And this, of course, can lead to a really destructive response. So let's take a look at some common examples of failure in medicine. This is looking at first-time test takers of standardized exams. This is 2021 data from the USMLE and ABIM. And so among medical students from US and Canadian allopathic schools who took the USMLE Step 1 in 2021, 4% failed. Step 2, 1% failed. And for ABIM first-time test takers, about 12% fail. But look what happens when people retake this exam. Now for Step 1, about just over 70% will retake it, and 66% pass upon repeat. For Step 2, 75% pass. And for the ABIM exam, 98% pass within a 3-year period. And so something is happening in between that is turning a failure into a success. It may be individual, they hone their test taking strategies, or they focused on a particular content area. It may be the external circumstances were more favorable for that applicant to take the test. And so something is happening. Let's look at another type of failure in medicine that's pretty objective. Not matching, right? Matching into a competitive specialty is difficult. And the reason I like this study is because it didn't just look at what percent didn't match, but it looked more closely at what are the factors that future applicants can pay attention to in order to have a successful outcome when they didn't match the first time around. So they took just over 200 former medical school graduates who were applying to dermatology at one of 6 institutions. And they did not delineate whether these were people who took an extra year for research, but presumptively the majority were reapplying to dermatology. And they identified those factors that will increase the likelihood of matching into dermatology. And what's neat about this is they actually developed some suggestions for mentors or advisors when applicants who failed to match in dermatology reapply. So for example, how should I approach the application next time? Well, in this study, those applicants who got 2 to 3 letters from dermatologists from institutions that train residents were more likely to match. Focusing on increasing or boosting your volunteer activity, not likely to help you match. And so it's a targeted way of sort of defining growth and success through our failures. And so we really need a systemic culture shift. We need to move in medicine from this fixed mindset of proving your ability, of my inherent intelligence is measured by some scale, to improving your ability and focusing on what we call a growth mindset, which is well known outside the spheres of medicine. And that is seeing failure as a stimulus for learning. Your ability can change, and it requires ongoing reflection, often coaching, as well as deliberate effort. And with that, I'm going to pass it to Andy, who's going to talk about sort of the history of how we learn from failure in medicine.
Thanks, Tamara. To learn more about how to embrace failure, let's go to an arena that's done a great job embracing it: medicine. ironically, we've done as a system a really good job of studying failure and learning from it. So let's go back to the early 1900s. Dr. Ernest Codman, if you don't know him, is the one that created the idea for M&M conferences. At Mass Gen around 1910, he came up with the idea to study deaths and complications that occurred within the hospital and come up with ways to prevent them in the future and make systemic changes that would lead to quality improvement. Unfortunately, not all of his ideas were as well embraced. He was actually let go from the hospital in 1914 after coming up with a similar plan for surgeons. Not going to say anything about that. He made good use of his time afterwards, though, and came up with a hospital standardization program, which eventually became JCAHO. So thanks, Dr. Codman. Moving ahead to the late 1990s, the landmark paper To Err is Human was written by Linda Cohn and Janet Corrigan, was released and highlighted some very concerning facts. About 44 to 98,000 people were dying each year due to medical error. This accounted for about 2 to 4% of deaths in the United States. It was shocking for the medical world and led to a revolution where we focused on these failures, found what changes needed to be made, and likely ended up saving hundreds of thousands of lives. We can see that not only was medical error a major focus for the medical community, but it was astounding and shocking for the lay community as well. That's why in the early 2000s, some of the most popular books were those written about our failures. Dr. Atul Gawande is my favorite. His hometown happened to be where I went to medical school in Athens, Ohio, but some of his books were bestsellers. My personal favorite was Checklist Manifesto, utilizing the aviation idea of checklists for everything in the OR. But what he did a great job of was sharing with the community what errors he was noticing within the OR and in the rest of the hospital, and coming up with ways of making change. And I think the reason he was so popular is because he was making it public. He was making it apparent that we're working on this, and our patients were reassured that the medical community was trying to change. All right, so moving ahead one more generation, from papers to movies, now to social media era. We're finding that a lot of our trainees and co-physicians are flocking to social media, be that Twitter or Reddit, to talk about everything from how to handle hyponatremia to how to handle their failure in the hospital. And whether that's because they feel more comfortable in this community or it allows them to post anonymously, this is an area where they're getting a lot of support. It took me about 2 minutes to find these different posts, some of them serious, some of them not, going over failures and their concerns. So this one in the middle, listing that I seriously harmed a patient, led to hundreds of posts from other contributors. And it's great that we have a spot for our learners and our co-faculty to talk about their failure, for them to be supported. But it begs the question, why don't they feel as comfortable going to their other faculty, to their mentors? That begs the question, why haven't we normalized failure within our community? We've done a great job at studying it in the system of medicine, but it's time that we start embracing it ourselves. So that makes us ask, why is normalizing failure important? I'm sure that each of us has had our own failures, some big, some small, and we've had a tough time dealing with them. But there are ways to improve this and ways to normalize failure. So starting with ourselves, we want to figure out ways that we can improve our way of handling it. And by doing that, we're going to be able to help others down the road. So how do we intervene? To do this, I'm now going to hand over to Eric to give you some more information.
Thanks, Andy. So we're going to focus on a toolbox of how we can transform failure into growth. The first thing I would like to review is this concept that comes from a book from James Clear. It's called Atomic Habits. And it talks about a valley of disappointment that you can see there on the graph. Basically, if you follow that straight line in the center, it's what he says, it's what we think it will happen. And then the one that's more curved is what actually happens. So what ends up happening is sometimes we have this idea that we're going to start something and it's going to be so amazing. It's going to be a straight line up. Yet in reality, many things take some time to take off. And there's that period that he terms the valley of disappointment, at which we could quit thinking, oh, this is never going to work. Just follow that line and look at what happens if you stick with it. There's a point where the growth becomes exponential. In a different book called Chatter by Ethan Kross, one slide back. Thank you. In this book by Ethan Kross called Chatter, he actually talks about the opportunity of, well, the whole book talks a lot about the voice in our heads that sometimes gets in our way of seeing things in a way that is helpful to us. And what he says in some parts is, if we see something as impossible, it's going to be really hard to address it. But when we try to reframe it as a challenge that we can handle, that alone puts us in the driving seat. And he says, remind yourself of how you have succeeded in similar situations in the past. That's kind of the concept of part of the book. If you have read it, you'll know what an amazing book it is. What we're trying to do really is not going down that rabbit hole that we saw. The problem when we let our mind spiral and the chatter go on is that something happens, something doesn't go our way, a door doesn't open or a door closes. And we start thinking about it, not in terms of something that could have been expected or part of that initial valley of disappointment, but more as we are the failure. And that, I think, is where it can become a lot harder to move from. So the idea we have coming from cognitive behavioral therapy, we have this concept of automatic thoughts. And automatic thoughts are really those ideas that are usually not based on reality, but yet our brain has interpreted over time as a reality. And you see there that automatic thoughts can become more intermediate beliefs, such as assumptions, attitudes, rules that we make for ourselves. And those can also become core beliefs. You see that those the arrows are bidirectional, because the problem we have is sometimes those core beliefs end up causing different intermediate beliefs. They end up determining the automatic thoughts that we have. Let's look at an example. Let's say I finish a presentation, I say, my presentations are pathetic. Think of the plural there and saying my presentations, all of them, and they always are pathetic. So then I think I really need to work harder to hide my lack of skills when I'm presenting. And some of that is stemming from a potential much more ingrained thought that I am useless. And that is what's really determining these moments where maybe I stumbled upon a slide, but no, I'm thinking my presentations are pathetic. And that's particularly what Chatter talks about. It's that moment where that voice doesn't let us see it in a different light. And it really keeps us in that rabbit hole that we saw. What we want to do over the next few minutes is go over a few skills we can use to reframe failure and look at it as an opportunity. So I'm going to hand this to Devorah, who's going to talk about that first tool.
So thank you, Eric. So the question is really, so how do we do this practically? You know, we've set this up already on the importance of reframing our mindset. So how do we prevent those automatic thoughts from necessarily becoming a core belief? And, you know, more specifically, if we're looking just at, you know, an immediate reaction to a failure, or even something that might have happened more remotely, but is still very raw, how do we shift our perspective so that it becomes more balanced? Could you go to the next slide? So here is a tool that we adapted based on our tried and true thought of tool of progress notes that, of course, we use in medicine all the time. And we adapted it using a very common tool in cognitive behavioral therapy called the thought record, which is from the Beck's Institute. And it's really a way to address automatic beliefs and prevent it from becoming a core belief. And hopefully with this familiar construct, it'll be a nice exercise. So we can go to the next page. Okay, So this is an overview of kind of overall what the whole exercise will look like. And I'll quickly just go through the individual steps and then we'll have an example. So first we start with the situation, and I'll go into specific once again in a minute. And then we do a reflection, which is really all the way going down to the diagnosis part. What is your working diagnosis when you think of a situation? What is your automatic thought or belief? Then we go to the evidence, the contributory part of it. So what are the pertinent positives and pertinent negatives that support this diagnosis? And then we want to consider the alternate diagnosis. What are the facts that don't support this diagnosis? And then we're going to go to kind of our assessment or our adaptive response, which is we're going to come up with a likelihood assessment based on the facts. We're using the word and really, how would you summarize this whole case to an attending if you had an attending in front of you? And then we're going to go to the plan or the outcome. And I'll talk about that a little bit later when we go through a case. Okay, next slide. So let's go to a case. We were thinking that a common situation for a mid-career academic physician that comes up a lot is career growth and promotion. So let's take a case. Let's think about, suppose you were a person who's been working for 10 years at an academic institution, and you recently found out that your application for promotion to associate professor was rejected. So now let's go to the reflection piece. What do you think is an automatic working diagnosis? What is an automatic thought that this person might have? There could be a lot of what we call hot thoughts and a lot of emotional reactions, but for the purpose of this webinar, we're going to say I'm a failure because that's really what we're talking about today. Okay, so now we're going to go to the contributory evidence based on our entire HPI. So what are the facts in somebody's career or in somebody's whole history that supports this diagnosis of being a failure? So this person could say, I'm a failure because, well, first of all, my application was rejected. Maybe they take kind of a personal perspective and says, well, my colleagues always talk over me. They don't really respect me. You could take something that's objective and say, my other people with less experience than I have were just promoted. And then, even more kind of personal thoughts, I'm always ignored. People don't really take me seriously. Now, we're going to consider the alternate diagnosis, like we always do in medicine. So what are the facts that don't support it? So I'm not a failure because, well, I recently was published. Maybe this person can reflect on how much time they've been employed. I have a loyal patient panel. And of course, there are a lot of external factors that go into a promotion decision. So now we go to the adaptive balanced response. So all the things that we said before are true, they are finding, and we're going to put them all together. And I think it's important, to use third person. Obviously, in this situation, we're talking about somebody else, but it's important to remind yourself to be balanced by using the third person. So I would say that a nice summative statement for this case would be a 45-year-old assistant professor with a history of 10 years of experience, a large and loyal patient panel, and recent publications, who presents after having her associate professor application rejected in the setting of a colleague with less experience getting promoted. So if you see here, the idea is not to negate the truth or picture it all in rose-colored glasses, but to attempt to kind of strip the emotional triggering and just look at it in a balanced way. We're scientists, this is clinical reasoning, this is what we do all the time. And then we do the outcome, which is the plan. And so if we assume that the working differential is correct, let's say in this case, I am a failure, what would be the result of this automatic thinking? What would the plan be? What would happen? So, you could say, kind of as Tamara was alluding to before, maybe it would inspire you, maybe it would push you to work harder, or maybe it would actually shut me down and prevent this person from actually moving forward in their career. And then the opposite, what would happen if you changed your thinking and really internalize that? Is there any advantage to changing it? And once again, this is not convincing somebody that they should feel one or the other. It's really just trying to take a step back, take kind of the hot thoughts out of it and the emotional acuity, and just give people perspective. I'll hand it back to Eric.
Okay, so that is a great tool for when something is happening and you identify that you or a colleague or a trainee is having those thoughts, and you want to be able to help them, challenge them in a way that is helping them reframe them, but at the same time challenge them using what they already know. And a lot of that drives from so many of the coaching strategies. So those are great for kind of in the moment things we can do. A different tool that we want to talk about is a failure CV. And I want to pause here and ask, you can put it on the chat or feel free to unmute. If anyone is familiar with this or has used a failure CV, keeps kind of a rolling failure CV for your own career. If you have, and if you could share, how is it that you build it? What do you put in it? Well, I see, what an interesting idea. So thanks. We'll go over a few examples. All right. So let me go through this example, and then maybe after that we can talk. And all I see, you're saying generating a list in your mind. So this is not something that we came up with. There is literature around having failure CVs in general. We do feel that this is something we can all incorporate in our careers. And I think the benefit is not only for ourselves. It really, I mean, if we do keep one, and I will share, I actually have one, and I've been working on my own. It's nice when we share that with trainees or we share it with colleagues, because it's a way to really make them feel and see that failure is normal. It will happen, and we can learn from it. And that's the take from a failure CV. It's not just about writing what didn't work and what didn't go our way, but more so reflecting on what were the possible causes, what can I learn from that, and where did I go from there. All of this can be pathways to something else in our careers if we take the opportunity to do so. And different from the tool that Deborah presented, this is not something you're going to do in the moment. This is more something that you will wait some time, reflect on it, and then come back with your learning points from a situation. So let's share a couple of examples. The first one, pretty relevant, from a year ago, we actually submitted this workshop to SGIM, to AppTeam as well. And we were rejected. So we thought, well, what were the possible causes? And these are some of the ones that we thought. Maybe the subject did not align with the meetings team, and it actually did not. Maybe the learning objectives were just not clearly mapped with the ACGME competencies as some of the societies wanted. Maybe the reviewers did not like the topic, and that's for anyone who has been on the reviewer side, you'll know that sometimes that does play a role. And then we thought, well, what are growth opportunities from this? So we can look for other venues. We can rework our learning objectives. We can even think of a different format. And funnily enough, we're presenting this today in a webinar format. So I think it's really proof that you can use those moments and really say, well, if this is information that you think it's worth presenting, then keep going with it. And we're very fortunate and appreciative of being here today. So planning on resubmitting and today already presenting it as a webinar. Let me share another more in my own role at the clinic and experience. So April 2018, I got a rejection for a position I applied to as a primary care obesity management director. So my reflection was, well, what could be the causes? So my first one was, well, I'm currently not certified in the in obesity, and the committee was possibly looking for more experienced clinicians. And then I thought, well, I can actually, as a growth opportunity, I could take my certification. And at the time, I was working in shared medical appointments for obesity, so continue working on that. And at the end, I actually looked for different opportunities outside of obesity. And I can say today, looking back, that applying and having gone through the process and the interviews actually helped me in the process and the interviews for a very different position that I applied to 2-3 years later. So that's what a failure CV can look like. And I want to go back into the chat I saw. Ola, you said we have a workshop that has been rejected 5 times by AppTeam so far. Don't give up. Yeah, so we're kind of right up there with you. So we know the feeling, and I think this is a moment where that's an opportunity to grow. And I mean, think about sharing this. And you're presenting it. Okay, there we go. So even more so, right? Like it shows how things tend to Oh, humor in medicine, nice. I would love to see it. All right. So we're going to shift gears a little bit and talk about a different tool. This tool is very different and it's very applicable to a specific situation. So this is for when you or a colleague is thinking not much else will happen in our careers. I think we've all been there where we think nothing will change. I'm stuck where I am. Nothing is going to either improve, change, develop. I'm not going to advance. So let's go through this exercise and I'll ask everyone to either think about this or write it down, and write it down not on the chat. This is for you on a piece of paper. Take a moment to think of how much change you think your career will experience in the next 5 years. So just think of where you are today, and if you can guess where you will be in 5 years, how much change do you anticipate? Write it down. You can also think about it. Try to keep track of how much change you're really thinking. We'll pause here for a minute to let you think and just really try to do that exercise. Okay, so hopefully you thought of where you are today and where you will be in 5 years. And now next to that column, think about how much your career has already changed in the past 5 years. So now look back 5 years. Where were you then? Where are you today? How much change has there been? Roles, cities, type of activities you do, skills that you use. And write it down on a separate column. Okay, so what I want you to take a look at is take a look at the two columns you wrote. Which one is longer? There's a phenomenon called the end of history illusion, and it's a psychological illusion in which across all ages, we tend to think that we have already experienced significant personal growth and that the future holds much less of that. So we think we're not going to grow as much in the future. We're not going to advance as much in the future, but we recognize we actually have advanced in the past. I wonder if this was your experience as you were doing these two different columns. And if we go to the next slide, you will see that across all ages, the reported change in the past tends to be much, much higher than the predicted change in the next 10 years. I'm curious to see if that's what you experienced if you went through the exercise. And I think what this highlights is that tendency we have of thinking that we really are stuck, that things are not going to change, but then we use our own selves as the control, and we realize, wait, I actually have changed all this much. I'm actually doing a role that's entirely different than it was 5, 7, 10 years ago. So what is my evidence that the future doesn't hold as much change? And I think it's a great way to challenge that assumption that things are not going to improve or grow from there. And as we get to the part where we hope to hear a little more about how each of us has handled failure in medicine, there's one quote that I want to share that comes from a podcast. The podcast is How I Build This. If you haven't listened to it, I highly, highly recommend it. It's by the host is Guy Raz, and he interviews people who have created companies or movements, and he talks about how they did it, hence the name How I Build This. What's very interesting is that almost every episode is more about like they talk about their initial failures. More often than not, people didn't just start with something and then hit the jackpot. It was really the failures that got them there. On a recent episode, he actually makes a point about failure being like the physical therapy you do after an injury. So you have an injury and then you actually do this physical therapy period where you're trying to get back into shape. And that's how failure can actually be seen as a moment to recover if you take the moment to look at it as that. Look at the quote. I think the quote says, "I think failure is just infinitely more interesting than success." That's really where people are at their most generous, when they're really talking about their failures. And it allows us to get a window into their soul that we need to have to help us when we are struggling with failure. I think what I love about the quote is the thinking of failure, sharing failure as an act of generosity. Generosity to ourselves, generosity to our colleagues, generosity to our trainees. So we wanted to leave you with that quote and hopefully help you see failure, and specifically talking about failure, as something that we really need to do more in medicine. What we would like to do now is we want to hear what you think about the tools, if you've used any of them. And maybe we can start with a question. One of the questions can be, well, let's just start with the tools that we discussed. Were you familiar with them? Have you used any of them? And we'll talk more about the different situations in a moment. And if you want to turn on your camera, if you can, that would be great. Hi, Ola, thank you. Not the CV, that's gonna be fun. Yeah, it's been fun to build it. Honestly, it's also a way when something doesn't happen, I've actually joked like, well, at least I know like it can go into my failure CV. So a positive in a negative. And Jen, I see the failure CV is a great idea, new to me. Oh, I think it's normal for it to be longer. I reflect back, I think that if we really are honest, usually our careers have much more failures than successes, right? It's that's true. When you did if you follow the end of history illusion, what did it happen for you that way, that you maybe underestimated the future change and when compared to the past change? Let's see a few yeses. And then on the chat, I see failure is the key to success. Each mistake teaches us something. Yeah, that's a great quote.
I'm just curious. I'm curious what people hear from their learners the most, like the most common failure that those that we teach come to us with. I don't know. What have you all experienced so far?
With learners, it's mostly the failure to meet their own expectations, which I think is fascinating because their expectations is like way above our expectations. So you have to like bring them down from their tree and tell them like, hey, I think you're okay, but you should think you're okay too.
I agree with that, Ola. I have found that many trainees, again, I used the quote earlier, and I think it applies to many trainees, is this idea of I have to be perfect. And if I am not, I'm certainly not going to talk about it. And I'm struck by how often, and this is really where this workshop, part of the reason this workshop was generated, how often trainees will come into my office and disclose a failure and talk about it, and yet they don't talk to each other about it. And it made me think that we're doing something that's helping to perpetuate this culture of don't talk about your failures, and we sort of perpetuate the shame in many respects.
I also think it's just interesting, like what you said, to see what failure is in the mind of our learners, because a lot of times what they think is a failure, I don't. And whether that's just because I had lower expectations when I was in their shoes, or just, being a learner is really tough and you set all these high expectations. I think sometimes just reframing it for them is helpful.
Also, I think that the exercise with the, looking forward and looking back is very helpful, because with learners, many times what they do is, especially with interns, they look at seniors. So they look forward and they're like, oh my God, I'm never going to be as smart, as competent as this, that, or the other thing. And then I ask them, like, okay, look at yourself 6 months ago. And they're like, oh my God, I was, like a deer in the headlight, and now I'm much more comfortable. So it helps them see it in perspective when you have them look back and ask themselves, like, how much have you grown? How much have you learned? How much more comfortable you are with what you're doing? So I think that's a really good exercise.
I agree. I'm also curious if people who are in roles in education as educators, if you have shared your own failures with your learners. And I see some nodding, and I know when I finally learned to be vulnerable to my trainees, it invited them in to speak. And it was a lesson for myself. If I'm not comfortable with my own failures, why am I providing guidance to other people? And so I'm curious if that has felt that way to others.
That you just brought up a great point, and thank you for the presentation. I just yesterday, one of my trainees, I very honestly said, thank you for giving me the courage to even talk about something that we were talking about. And it allows this safe space that both people, because in the end, I love the FAIL acronym, because in the end, we're both kind of learning from each other. And it's one of the reasons that many of us are in medical education, because we are kind of learning as time goes on as well. And I felt like that was, someone that I hope in the future is going to reach out whenever they need. And I think sometimes the other thing that we do in medical education, we're always, and I think in medicine in general, we're always focusing on the success, like as you mentioned, you get these announcements, about, promotions and things like that. And especially during fellowship time or jobs when people aren't able to match or what have you, they feel like they're just one, when they may not have realized that maybe the years before this had happened. And I think that that's really hard, because we also have to be very protective of those who may not have matched, but is that also like the perception that the learner has, because this is what they're hearing. They're seeing that match list and they're seeing how people were able to match, but we're not going to announce, of course, the people who didn't match, but that's kind of the perception. Every third year class we get this. So just the 2 points I just want to make. But yes, just I was very honest. I just said I again, it's that honesty and that courage and the vulnerability that you mentioned, that I was very clear saying, thank you for giving me the courage to be able to share what we're talking about.
It's a powerful response. I feel like that's what we do it for.
Dr. Osorio, not surprised to hear that. I think having been in residency with you as an APD, I know how you can make residents feel comfortable talking, and it was nice seeing you and hearing you for a moment. It actually led me to think of with this concept of the failure CV. A few years ago, it happened that a resident here did not match, and in talking with him, I was trying to convey that things are going to be okay, that he's going to learn from this, that he's going to grow from this, and that this is going to lead to a better place, and that he cannot see it in the moment, but that he will. And all I kept thinking inside is like, if only I had shown him my failure CV before this, then I wouldn't have to because right now it almost felt like I was saying it because it's the right thing to say in the moment. So that's another concept for those trainees that if you do keep this failure CV, it's a gift you can give to others. If you show them that you're doing, then the day that you need to actually come and share that, they will know that you mean it. You're not just saying it, you actually have it. But in the moment, otherwise, it's so hard to see. And that was it's a thought I had as I was reflecting on this idea of when we hear about someone going through failure and we want to tell them it's going to be okay. So if you do keep this and you actually share it beforehand, it can be extra powerful, because then when you share it, you can even say, hey, one day this is going to be an entry in your own CV, and it's going to be okay. Although it doesn't feel like that right now. Ola from the chat. I think it's also, you wrote, I think it's also important to acknowledge the grief that we and our learners feel when we fail, and it's a valid point, right? It's a moment that like with all the stages in grief, we have to go through them. For some of us, that may be a short period. For some, it may take days or weeks. And sometimes acknowledging it can mean so much to the other person. I like that you also talk about your own grief. I think as teachers, as anyone in medical education, it's an interesting point. I wonder what others think, but like when a resident fails, how do we feel? And do we also think we may have failed? And there's also a little bit of grief in that. I personally say I don't think I had ever thought about it in that way, and I think it's so true. I think there's a component of grief that's our own grief, even when the failure was not ours directly.
I love that, Eric. And I think you do I would like to think I've become more comfortable in my failures. And I'm reminded of this as you're speaking. There was a resident who I worked on a manuscript with, and it got rejected, and she was devastated, absolutely devastated. And I realized my reaction was one of just keep your head up, move on, let's submit to the next. And, 5 years ago, 10 years ago, I'm not sure I would have been that forward thinking. I would have probably shared in that devastation. But I think to your point about that last slide, it's a moment where you can see our potential for growth keeps coming, and these opportunities keep coming. I love this. It's common to try and reframe everything as positive, and it almost takes away the opportunity to grieve. There's this toxic positivity that we sometimes will not intentional surfaces in moments of failure. And I love that idea of it's important to recognize that. Most people are not looking for that when they've gone through a failure.
Well, the reason I put it out there, Tamara, is like you said, because I like that you called it toxic positivity, because there is this tendency, like we all live in this, everything has to be good. Everything we share is just the successes and the good stuff. So it's very common that if somebody comes to us with a failure or with something that they perceive as a failure, we're like, oh, it's okay. It's a growth opportunity. You'll grow from it. It's going to be good. It's going to be great. But for them, they're not there yet. So we have to give them that opportunity.
Ola, if I may share my screen, I wanna show what you just sent, because I think it's hilarious, and I think this would be for everyone to see. Let me just figure this out 1 second, because I just started reading it and I'm cracking up. Let me show everyone.
It's really funny. That's why I put it there.
Yeah, so Ola just shared with us. For those of you who are following the chat, you may want to go to the link, and it is a journal of universal rejection. So I guess what I take from this is that we've all been there, and we're able to see it with humor, but basically it says that the founding principle is rejection, universal rejection. Every submission, regardless of quality, will be rejected. And despite the drawback, there are a number of reasons. You can send your manuscript here without suffering waves of anxiety regarding the eventual fate of your submission. It will be rejected. There are no fees. You may claim to have submitted to the most prestigious journal because their acceptance rate is so low. And you get to keep all the rights to your work. You're free to resubmit to anywhere you want, even before the review process is complete. So at any point, I think that's awesome. And I think just seeing another interesting point that I'm looking at it is, one, there's more than just the US, there's many in the UK. And also if you see like, certainly like not all of them, definitely not coming from medicine. So I think it speaks to the universal idea of, can we normalize rejection and not make it a stressful thing? That's awesome. Thanks for sharing.
I just like that you can get an individual subscription for the low price of $10,000 a year.
All right.
Any other thoughts or comments before we depart? Okay. Well, we just want to thank AIM again for inviting us to speak. We hope this has been a moment for possible reflection and growth on your parts. And it certainly has for all of us. So thank you to everyone. I think we'll put Eric, do you want to put your handle in the chat maybe? So for those of you who are interested in sort of continuing the discussion. Thank you so much to everybody.